We come to the last but not least of our keynote speakers, and it's my privilege to introduce you Honorable Reverend Dr. John G.N. Sikosing. He is the Minister of Health of the Republic of Botswana, and as you can tell from his titles, he is a Renaissance man. He is an ordained minister, so he's a minister of religion as well as a minister of health, and he's a doctor of medicine. He qualified in medicine in Russia in 1973. He's long been active in politics as well, and in 1963 to 1966, early in his life, he worked as an executive assistant at the Office of the President in Zambia. He's run for offices and since 2009 has been a member of Parliament in Botswana. In addition to those activities, he has volunteered widely his professional expertise, and he represented Botswana's Red Cross Society under the auspices of the International Committee of the Red Cross in Iraq in 1991. He has many interests. He's an author, and his other interests include ballroom dance, dancing, music, writing, and drama. He is married to his wife, Lula, and they have 3 children. Please join me in welcoming Minister Sikosing.
Your Worship, the Mayor of Berlin, Honorable Minister of Health, the President of the World Health Summit, the academicians present here, ladies and gentlemen, let me begin by thanking the organizers of the World Health Summit for inviting the government of Botswana to participate in this very important forum. We are indeed grateful for the opportunity to share our vision of the global health agenda and our views on improving the structure and capacity of healthcare services to enable a sustainable, equitable, and effective health system. The theme of this year's summit, Research for Health and Sustainable Development, is timely. It focuses on issues and possible solutions for non-communicable diseases and other conditions of global concern. As a national health leader, I am encouraged that the issues that my country faces are given an international platform from which we can discuss, debate, and pave a new way forward. My address today will focus on 3 main areas. Firstly, Botswana's experience with the epidemiological transition from communicable diseases to non-communicable diseases, and the dual burden of these diseases that we now face. Secondly, our approach to promote an integrated healthcare delivery system for both communicable and non-communicable diseases. And thirdly, the efforts we have made in promoting evidence-based policies to confront non-communicable diseases. Most of us in this room today have witnessed the epidemiological transition in our lifetime. Botswana, like many countries, has experienced economic growth over the past 20, 30 years. With that growth, my country has invested in health, education, roads, clean water, and increased opportunity for employment and upward mobility. In fact, in June of this year, Secretary Hillary Clinton mentioned Botswana and Norway as 2 examples of countries that discovered large stores of natural resource and dedicated a portion of the income to health and education, as well as credited us with saving lives and lifting communities. Many of you that are familiar with these countries and their ongoing initiatives will indeed agree with these remarks. And for us, the people of Botswana, these words give us a great sense of pride about our country. With these technological and economic advances, we would expect to witness an epidemiological transition where infectious diseases, particularly vaccine-preventable diseases, malnutrition, and maternal mortality become things of the past. But, unfortunately, non-communicable diseases such as heart diseases, cancer, diabetes tend to rise and dominate the national health care needs and systems. The term epidemiological transition may be thought to imply that we would have eradicated our infectious diseases to focus exclusively on problems associated with non-communicable diseases. I'm here today, ladies and gentlemen, to stress the fact that this is entirely not the case. In fact, the word transition masks the much more complex reality that is faced by Botswana and the rest of the African continent. It is the dual burden of disease, where the rates of infectious diseases remain high, and there is a growing burden of non-communicable diseases that we must address, and address swiftly and decisively. This dual burden of disease and the challenges it brings is laid out clearly in the case of HIV/AIDS. Botswana has experienced high HIV prevalence rates for the past 3 decades, with HIV prevalence among the general population estimated at 17.6%. I know it's shocking for both of you. Yes, at the height of the epidemic, it was a race against time to get services and treatment out to the population quickly. And we did so by creating a stand-alone system to deal with the influx of HIV/AIDS patients that were overwhelming our existing health services. At the time, this was what needed to be done. And it indeed has resulted in a success story that we are always proud to share with the rest of the world. By the end of August 2012, a total of 196,093 patients were receiving HAT in Botswana, which amounts to 97.2% of the projected 201,827 adults and children in need of ART. According to ANC Sentinel surveillance, trends in HIV prevalence among pregnant women aged 15 to 49 years have been declining. The national HIV prevalence among pregnant women attending ANC declined from 36.2% in 2001 to 30.4% in 2011. Though declining, this is still high, putting children at risk of acquiring HIV infection from their mothers. However, the testing outtake for PMTCT program has increased from 83% in 2006 to 98% in 2011, while the program uptake of pregnant women receiving either AZT or highly active antiretroviral therapy has increased from 83% in 2006 to 94% in 2011. In addition, of the 86% of HIV-exposed babies tested, 96 to 97% of them were HIV negative. triple ARV prophylaxis, and HEART for all HIV-infected pregnant women, to further reduce transmission rate to less than 1% by 2015 from the current 4%, will be rolled out by the end of November. Other prevention efforts include scaling up safe male circumcision nationally as an add-on strategy for HIV prevention, targeting HIV-negative males of up to 49 years. In this endeavor, dedicated safe male circumcision teams have been deployed in high-volume health districts to provide the services. We have challenges in meeting the set targets, but new initiatives are ongoing to address this. As you might all be aware of, Botswana people are not necessarily a circumcising nation. Circumcision to us is a new system, is a new thing altogether. So it's quite an effort to pull all those men to circumcision. But we are trying hard, and we believe one day we shall reach our target. Furthermore, we have adopted the WHO Protocol on Early Initiative of ART by starting patients on ART at CD4 cell count of 350 and below. The benefits of this intervention are reduction of HIV transmission, opportunistic infections, and general improvement of health, thereby saving life. But these successes and the standby alone system brings in new challenges. The leading cancers in Botswana, the cervical cancer among women and Kaposi sarcoma among women, are associated with the country's high rate of HIV. Adults who are on long-term ARV treatment are thankfully living longer, but are also at higher risk for cardiovascular diseases and diabetes. AIDS itself is now a chronic disease which will require the same type of continuity of care from initial diagnosis to treatment, as is the case with other non-communicable diseases such as heart diseases and diabetes. And it is not just among our adult population, but children as well. In Botswana, we are seeing increased rates of obesity among young people, and yet there are still many children under the age of 5 that are malnourished. Maternal undernutrition during pregnancy, which increases the risk of the infant developing chronic conditions such as diabetes and cardiovascular disease later in life, should also be a priority as we think about how to address this dual burden of disease across the lifespan. Maternal mortality, including in HIV positive population, is still very high in the country, 163 per 100,000 live births. That is very high in all standards, and is being given, but it is being given the necessary attention nevertheless. The time is now for integration of health services and the implementation of evidence-based policies and practices. With the global economic downturn, we no longer have the luxury of waiting for a huge influx of resources to address these issues. This is the moment for us to think creatively, building upon the public health infrastructure already in place and finding the most effective and efficient points to intervene so that both the infectious and the chronic conditions can be prevented, diagnosed, and appropriately managed. My ministry has embarked on an ambitious agenda to harmonize and align health sector planning, implementation, financing, and monitoring and evaluation. These include a revision of the national health policy in order to prioritize issues related to health sector, a more appropriate focus on key diseases and conditions beyond HIV/AIDS, improving organization and management of the sector with the inclusion of the private and NGO sectors. And finally, to redress health service weaknesses to attain our National Vision 2016 goals as well as the MDGs. Within this framework, the Ministry of Health has also developed an integrated health sector policy as well as prepare for the future health needs. An essential health package that is also in line with the policy has also been developed to strengthen the health system. It is not just health services, but prevention that we must also put at the forefront of our efforts. The majority of non-communicable diseases, deaths, are linked to risk behaviors such as physical inactivity, poor nutrition, alcohol use, and tobacco use. We have seen high rates of these behaviors in Botswana, and not surprisingly, high rates of high blood pressure and obesity, especially among women. As a country, we are committed to implementing sound, evidence-based policies that will help to confront and prevent risk factors associated with non-communicable diseases. Botswana has taken aggressive steps to reduce alcohol use through taxation, reduction of hours of sale, and increasing fines and penalties for drunken driving. We have seen some positive results, namely 12% decline in adult per capita alcohol consumption, and are working to continually monitor and track our success. We have also begun to address the informal alcohol market by introducing traditional beer regulations that outlaw alcohol being sold in the home and instead requiring that alcohol be sold in more formal locations that can be regulated. Tobacco is another area of focus. Botswana is a signatory to WHO Framework Convention on Tobacco Control, which has played a catalytic role in shaping our tobacco laws. Whilst we were among the first in the continent to develop the first tobacco law in 1992, we were also among the first to start implementing the Articles 8, 13 and 16 of the Framework Convention on Tobacco Control in 2004, immediately after signing the framework. We have active NGOs on tobacco control that were initiated following the FCTC ratification. We are now poised to implement a new tobacco control policy that will address the remaining requirements of FCTC signatories, namely taxation of tobacco and comprehensive smoke-free indoor air laws. Finally, we are exploring policy options that will improve physical activity and nutrition to help further prevent non-communicable diseases. These are some of the current initiatives that are ongoing and are a prime example of translating evidence-based policies into practice. We appreciate forums such as this one to share our experience and believe that networks such as M8 Alliance provides us with an opportunity to learn what is out there and broaden our own networks. We still need additional guidance and support to bring us to the next level of integration, policy development, and evidence-based programs that will work in our context. We need funding streams that will assist us with integration and will avoid creating further silos and stand-alone systems. We need practical applications and experiences of recommended policies and practices, and we need to ensure that these approaches work and result in the goals and objectives that we intended. So your ideas in this regard are welcome as we walk together toward realizing our needs collectively. Let us not forget that in the end, the issue of non-communicable diseases is not just a health issue, but a development issue that impacts on our society as a whole. Let us not forget that we have to address both communicable and non-communicable diseases in a comprehensive and integrated way. And let us be bold and imagine a new way forward that builds upon the strong foundations that have been built and brings us to another level of sound and swift public sector action. Ladies and gentlemen, I thank you very much for your listening.